presentation from Atlantic Urology on men's sexual health and wellness. I am Dr. Guy Bernstein, and I've been in practice for 36 years in the suburbs of Philadelphia. I have focused on a lot of different areas of urology, but close to my heart is working on men's health issues and specifically in sexual areas, and we'll cover some of those topics this evening. There will be a recording of this, so those who either can't dial in or want to listen further will be able to get the recording. It will be sent to your email with a link, so you'll be able to review it as well. You can ask questions as we go along. I'll probably wait till the end to answer some of the questions, as some of those may already be answered. So let's dive into the questions and the issues here with men's health. Why are we discussing this? Well, number one, it's important to both the physical, mental, and overall well-being of both men and women. Studies have shown that women are more knowledgeable about sexual health than men, and they're more likely to seek answers to their questions either with their physicians or even in walk-in clinics. In a Cleveland Clinic survey from 2023, there are a number of issues that men are concerned about as they get older, including erectile dysfunction, libido, testosterone. And so we do want to cover several of these issues. Realize that a lot of men worry about it, but they don't seek help. And we as urologists, and Atlantic Urology specifically, are well geared, well knowledgeable on these various areas. So we'll cover things like low testosterone, Peyronie's disease, which is curvature of the penis, premature ejaculation, vasectomy, fertility, and erectile dysfunction. Obviously, these are a lot of big areas, and any webinar could cover any one of these for an hour. We're going to just dive in and give you a little bit of taste of each of these, but these are things that you can ultimately sit down and go over in more detail with a urologist. So let's talk about low testosterone. It is common. It does occur more often as men age. There are different assays that look at testosterone, so the range of normal can differ a little bit depending on which assay is used. An assay means the blood test. The best time to check a testosterone level is in the morning. That's where everything is standardized towards. And there's both a total testosterone and a free testosterone that can be obtained. It is more common in men who have obesity and or diabetes. In fact, about a third of men with diabetes have low testosterone. It also is more often seen with other health issues related to cholesterol or high blood pressure. What are typical symptoms? That can be fatigue, loss of energy, sexual dysfunction, lack of libido. Those are probably the most common ones that I see. And in fact, oftentimes drives men into the office is because of how it impacts on sexual function. However, there are plenty of other symptoms associated with low testosterone, including feeling sad, less energy overall, less self-confidence, poor concentration. Men describe it as a brain fog, hot flashes, loss of hair, increased body fat and loss of muscle mass. It's very important when we sit down to discuss low testosterone that we get a sense of what are the symptoms that are driving the evaluation of low T, as it's oftentimes called. And it is important that it's not just for sexual health, because it does aid in bone, cardiac, mental, and psychological health. Anyone whose testosterone level is low or low normal could benefit from treatment, but a physician should really manage it. There are a lot of websites now that offer testosterone therapy. There are a lot of testosterone clinics that are oftentimes not managed by physicians, or certainly not always by urologists. We are the experts in this. We can help drive it. There are some issues with regard to risk of testosterone therapy, and there are multiple ways of treating testosterone, as we'll talk about in a bit. So that it is important that you work with a professional who is well knowledgeable on testosterone therapy. The treatments that are out there right now include testosterone gels. There are 3 oral medications approved. There's a nasal spray. There are testosterone patches. I'm not a big fan of that. There are testosterone pellets that are inserted, and there are injections, either short-acting injections or long-acting injections. The shorter the duration of therapy, the more likely you're going to get highs and lows. The real goal of testosterone therapy is to get a steady state. Realize that when you're getting testosterone therapy exogenously or through one of these different treatments, your own internal testosterone is suppressed. So you're really replacing your own internal testosterone with this external testosterone. And it's very important that it be monitored on a regular basis, both to make sure that you're in the range. We don't want high levels. We want to be in the mid to upper end of the normal range. We also want to check your hemoglobin, because one of the things that can go up with testosterone therapy is your hemoglobin. And if it gets too high, that can be a problem and actually carry some risk with it. The other things that people get concerned about is how is it going to affect my prostate? Suffice it to say that all studies have shown that testosterone therapy does not cause prostate cancer, but clearly if someone had prostate cancer undiagnosed, it'd be important to know if that was the case. And so again, in my practice, men who are on testosterone therapy are seen every 6 months to check their testosterone levels, to check a CBC and their hemoglobin, and to check a PSA. That's the minimum. You may also check things like liver disease or liver function and renal function, thyroid function as well. But again, the very minimum is to check those other areas. Let's talk a little bit about Peyronie's disease. Peyronie's disease is curvature of the penis. Peyronie was a French physician who made the diagnosis or created the condition, and it really relates to a plaque that develops in the penis. It can present acutely with trauma during sexual activity. It can also present as sort of mild trauma that over time creates the curvature. The most common curvature is on the top of the penis, and it curves up towards the belly button, but it can also the curve can occur in the right or left direction, or even down towards your legs. It is most common over the age of 50, and most likely for many men relates to the fact that the erections aren't as firm as they used to be, and you're getting minor trauma with vaginal penetration. It is definitely underdiagnosed and undertreated because a lot of people don't know who to go to when they have this curvature, and some primary care physicians aren't as comfortable with this condition as well. They estimate that as many as 10% of men have Peyronie's, but it could be even more than that. It can cause pain with erection. There can be loss of length with erection as well. Treatment can include devices. There's a device called the Restore X that was developed by a urologist at the Mayo Clinic. And it's almost like putting your penis in a rack. They have scientific evidence that it extends the length and straightness of the penis. There's a medication called Xiaflex that we inject into the plaque to soften it and break it up. It's a series of injections between 6 and 8 over the course of many weeks. And studies have shown that in combination with the Restore X traction device can actually work better than either one alone. And so I oftentimes encourage my men to purchase the Restore X online and go with medication, assuming it is appropriate. And there is an imaging study we do ahead of time with ultrasound, so we better understand where the plaque is, the degree of curvature, and if there's any calcification in the plaque. Finally, there is surgery that can work as well. And that surgery can either be something called application, where we tighten the other side of the penis to straighten it, or you can incise or excise the plaque and put a graft in place. And there are a number of different graft materials that you can use. Or finally, if someone especially has a weak erection and has the curvature, You can use a penile implant. We'll talk about that a little bit more, as well with men who have erectile dysfunction that's unresponsive to other treatments. We'll move on to the next subject. And again, this is really just touching each of these with some information. The next is about premature ejaculation. It is a very common condition. Guys are always surprised that they're not alone in having this problem. And basically, the definition of premature ejaculation is climaxing before he or she wants, typically within a minute of sexual activity or shortly after penetration. There are a number of causes. It can be because you have a new partner and a little stress or anxiety. It can be that you had a long time since your last ejaculation. There can also be anxiety over pregnancy concerns or guilt if it's outside your marriage. It can be related to depression. And there are hormonal issues as well. And I oftentimes will check, at the very least, thyroid and testosterone to be sure that those don't play a role. There are a number of different options with premature ejaculation. You can get counseling and behavioral therapy. You could reduce your intake of alcohol, tobacco, or drugs, which can sometimes play a role with premature ejaculation. There are relaxation exercises to help delay ejaculation. There is a class of antidepressants, which as a side effect, they delay ejaculation. For guys who have normal ejaculation, it actually can cause a difficult time where they're delayed too much. But for guys who have premature ejaculation, the medications can inhibit or delay orgasm and can be very beneficial at a low dose and can oftentimes be taken the day that you know you're going to be sexually active. Again, this is not the approved use of these medications. It's what we call off-label, but it definitely is effective. And truthfully, it's the most common approach that I use in treating premature ejaculation. There are also topical therapies. There are anesthetic creams and sprays that you can apply to the head of the penis before sexual activity that creates a little numbness there and may delay the sensitivity and the orgasm as well. Let's talk about vasectomy, something I know a lot about. I do typically 4 to 8 vasectomies a week, and I've been doing it for 30 years. It is a means of creating permanent sterility. It's a very simple procedure, I would say 99.9% of the time done under straight local anesthesia. But if someone was very anxious, you could use nitrous gas. You could even use sedation anesthesia. But again, the vast majority of people I operate on with just straight local anesthesia. We are interrupting the vas deferens, which blocks the flow of sperm out of the testicle, but does not affect either erection or ejaculation. And in fact, the volume that you ejaculate is almost the same because most of the fluid is fluid that is created downstream. In my hands, it takes under 10 minutes to do, but some people can take 15 to 30 minutes. Recovery is really a few days. I typically have people use ice, Tylenol, and support. I recommend no strenuous activity for the first week and wearing something supportive for that first week as well. If after a few days there's still some discomfort, it is not unreasonable to start using an anti-inflammatory because oftentimes the inflammation can arise. There is no long-term risk from a vasectomy. There were studies years ago that suggested it could increase your risk for prostate cancer, but all the subsequent studies have said that's not true. Really, the only risk is of an issue where you can have some ongoing discomfort several weeks or months after a vasectomy, and it's extremely, extremely rare. And again, there are a number of different techniques that can be done to try to reduce that from happening, or if it does happen, to treat it. Again, it does not affect sexual performance or orgasm. It doesn't change what the semen looks like. It is not designed to prevent STDs, and reversal is possible. Again, I do a lot of fertility work, which we'll talk about in a second, and some men can either reverse a vasectomy if they choose to have children with either the same or another partner, or their means of retrieving sperm if a couple wants to proceed with IVF or what's called ICSI as another means of achieving embryos and fertility. Let's talk about male fertility or infertility. Realize that although oftentimes the female partner is the one who initiates the fertility evaluation and treatment, men are very important in this process. Probably at least 30 to 50% of situations where a couple cannot achieve pregnancy, it's because there's a male issue involved. And if we look at statistics, about 15% to 20% of couples are affected, as we're seeing more and more couples opt to choose to have children later in life. That has increased a little bit, in part because female fertility does decrease in their late 30s. And also, obviously, there can be delays either because of late onset of marriage or late onset, as we just talked about, of looking for fertility. We do know there are many choices, many options in terms of approaching fertility or infertility. And when I see a gentleman for male factor infertility, it requires a good physical examination, seeing if they have any testicular issues, if they have any problems with their vas deferens, with something called a varicocele. We do hormone profile to see if there are any hormonal issues that are playing a role. And obviously critical is the semen analysis to see what the sperm count looks like, what the motility and the morphology. Motility meaning what percentage of the sperm are swimming and how well do they swim. And morphology meaning what does the sperm look like? Do they have the normal appearance? There are standards that were created by the World Health Organization that we look at to determine if someone has normal fertility or is subfertile. And as I said, there are a number of things we will look at. We know that certain things environmentally can play a role, or behavioral. Too much alcohol, too much caffeine can have a negative impact on sperm. Clearly, recreational drug use, and specifically marijuana, can have a very strong negative effect on sperm. The life cycle of sperm are 60 to 90 days. So if you change something, it could take 3 months to see the benefit and see improvement in the semen parameters. Obviously, there are conditions that can affect ejaculation, like diabetes, like MS, like a spinal cord injury. There are things that can affect the testes themselves that are pretty obvious. If you've had mumps as a child, or if you've had testicular cancer, those are some obvious things. And again, the history, the exam, and these laboratories are all critical. We talked a little bit about the tests needed to diagnose infertility or to assess for fertility. Sometimes we even have to do a biopsy of the testicle to determine if the testis is making sperm, but they're not getting out into the semen and then being ejaculated. We did talk about certain things with regard to lifestyle changes, just mentioned that. And there are some surgeries that can be done to improve the situation. The most common thing we see, and occurs maybe 40% of men who show up in my clinic for fertility, is a varicocele. These are dilated veins in the scrotal sac, more often on the left side than the right side, but they can be on both sides. It is a surgical operation, very simple, but it has been shown to have significant impact in someone who has low sperm count or motility in improving those parameters. Obviously, if someone's had a vasectomy, you can reverse it. It has a high success rate in the first 6 to 10 years after a vasectomy. As you get further out, the success rate does decline. Some men opt instead to aspirate or collect sperm either from the epididymis or the testis, and those sperm are then used in an andrology lab to fertilize the eggs that have been harvested from their female partner. Again, that is what we call IVF or ICSI, and those are different techniques to create embryos in the labs. Obviously, as a urologist, my goal first is to see if we can get a couple pregnant at home, but we do have the option of working with many good fertility groups around the area who work on the female side and can be very helpful in helping achieve a pregnancy. And for the final topic, let's talk about erectile dysfunction. It is a big part of our practice. Approximately 1 in 5 men will experience some erectile dysfunction. Sometimes it can be temporary and related to certain issues, stress, diet, weight. But there are plenty of men where they do need treatment. And obviously, we've had great treatment for the several years with regard to drug therapy, but that has also expanded into other options as well, as we'll talk about. To have a good erection, you have to have good blood flow into the penis and good trapping of the blood in the penis. And those things can be affected. Obviously, blood flowing into the penis can be affected by things that affect blood flow in any location, and things like atherosclerosis, high blood pressure, diabetes, obesity, elevated cholesterol that can damage arteries elsewhere, can damage the small arteries that carry blood to the penis. In addition, when the erection occurs, there has to be trapping of blood in the penis. And some men will have something called a venous leak, where the blood goes in okay, but doesn't stay in there and leaks out. And there are ways of treating that, although sometimes it requires the use of compression devices on the base of the penis. There are studies, again, we can do to determine whether this is a arterial or venous problem. That helps us sometimes determine what are the best treatment options. That study is called a duplex Doppler ultrasound of the penis, where we do ultrasound imaging and blood supply imaging to the penis before and after we give you an injection to create an erection, so we can see the dynamics of what changes before and afterwards. Obviously, we look at things that could affect it, and here's listed many things, including medications. Any high blood pressure medicine can affect erections. Obviously, knowing about diabetes, knowing about previous pelvic surgery or low testosterone or having radiation to the pelvic area can all play a role. And obviously, unfortunately, many of our treatments for prostate cancer, including surgery and radiation, can have impact on erections. And we talked about already, 3 of the big areas are vascular disease, diabetes, and obesity and cigarette smoking. Let's talk about diabetes, because obviously it's a very common condition. Millions of men have diabetes in the United States, and ED occurs typically 10 to 15 years earlier in men with diabetes than men who don't have diabetes. At least 50% of men will have erectile dysfunction who have diabetes. Obviously, the better the diabetes is controlled, the better the chance that you will not progress onto erectile dysfunction. But even in men who do a great job, unfortunately, sometimes ED is going to be there. Let's talk about heart disease. And this is very important because erectile dysfunction can precede the vascular problems that occur in the heart or other parts of the body. And if we see ED in a young man, it's very important that we evaluate them for other conditions that they might not already know about, such as their cardiac status, or if they have diabetes, or if they have peripheral vascular disease. It's amazing that so many men, young men, don't have a family doctor, and their first contact with physicians may be through the urologist. And obviously, if we're the first one seeing them, it's very important that we take a broader approach and appreciate that the fact that this may reflect, as we just mentioned, something else going on. And so it'd be very important to check a triglyceride level, check a sugar level, check a cholesterol level. Make sure if they haven't had any cardiovascular evaluation that they have something very basic done. Here, this shows basically the size of the arteries compared to other arteries. And so you can see that, and we call it the canary in the coal mine for heart disease, is that if the penile artery is affected, you can be pretty sure if it's a young person that could be affecting any of the other areas that could cause chest pain, angina, or even a heart attack. Can cause a TIA, which is a temporary ischemia of the brain, or a stroke, and obviously something called claudication or leg pain while walking. So again, these are all things that are very important to be aware of. Now, obviously the blue pill, which was the major breakthrough in treatment for ED, and occurred so many years ago and made such a difference. Obviously, that we're talking about is Viagra. The generic name is sildenafil. That's what most men take now. And they take doses ranging from 20 milligrams to 100 milligrams. Some men take more, although there are no studies that show that more than 100 milligrams makes any big difference. It increases blood flow to the penis. It does require sexual stimulation. Just taking it by itself isn't necessarily going to do anything. It's effective, as you can see, for 50 to 85% of men, but men who have more significant vascular disease or have had prostate surgery or diabetes, they may have less responsiveness to this oral medication. Now, I should mention, for fairness, that obviously the other drug that's been approved and been out there for many years is Cialis, or tadalafil is the generic name. That men take anywhere from 5 milligrams to 20 milligrams. Cialis is approved to be taken daily or taken as needed. If you take either one of these pills as needed, you want to take at least an hour before it works. For Viagra, the typical span of effectiveness is 6 to 8 hours. For Cialis, it's 36 hours. There are some potential side effects. The big areas are headaches or facial flushing. You can get nasal congestion. You can get some GI distress. There's very minor side effects like visual changes where you get a little blue vision. Down here, it's listed as prolonged erection, something we call priapism. I've almost never seen it with the oral medications. There are other treatments that can give prolonged erections, which are dangerous, and we'll talk about that in a little bit. But really, for most men, this is the starting point. You check testosterone levels, you might check thyroid function, you'll check cardiovascular status, and then you'll offer them this medication to see how it works. Typically, you'll want a trial for 30 to 60 days to see if they have benefit. They may need to adjust the dose, and that's oftentimes a starting point. Some men come to me because they've already had the treatment with their primary care physician, and it's not as effective. So what else can we offer them? There are vacuum devices that create negative suction and then draw the blood into the penis. Again, after you get the erection, and it's a little bit of a cold erection. It's not a warm erection like you get with Viagra, Cialis, or with some of the other things we'll talk about, but you have to put a ring at the base of the penis to keep the blood trapped in. This is the same kind of ring that I should have mentioned. If you have that venous leak that we talked about, that some men can get an erection, but they don't hold it, they buy a ring. Sometimes it's a solid ring, or it can be almost like a lasso that you can put down at the base of the penis to keep the blood trapped in. Again, there are websites where you can buy this vacuum device. You also buy online, and there are websites for it as well. If you Google vacuum device, you'll see a number of companies that make different products, electric, manual, different costs for it, depending on who you're purchasing it from. One of the very popular ways, believe it or not, and especially was popular before Viagra and Cialis, was injecting medication into the penis. You can inject a single drug called prostaglandin E1, but most of us have men inject what we call a triple mixture of prostaglandin, papaverine, and phentolamine. The erection occurs within 3 to 5 minutes of the injection, and I typically teach men how to inject themselves in the office, and then they go home and inject. We want to make sure that the erection lasts for about an hour. This is where you have to be careful, because if you dose too high, you can have a prolonged erection. That is called priapism. Typically, if an erection lasts more than 6 hours and it's firm for those 6 hours, you need to bring it down with an antidote, a drug that you inject into the penis to deflate it and allow it to restore its normal function. You do not want to leave an erection for hours and hours, because it can be damaging. And once the penis is damaged, it may be less responsive to other therapy. It may create scar tissue in there or plaque. And besides that, it can be very painful to have a prolonged erection. These medicines can last for months to even 6 months, kept refrigerated. I typically will have a compounding pharmacy or a specialty pharmacy prepare this. The reason is that the FDA approved drug, which is a just single prostaglandin E1, is very expensive, and many insurances don't cover it. So in my practice, again, I work with men to make sure they understand how to do the injection and then order it for them from a compounding pharmacy. Some of the newer treatments, there is low-intensity shockwave therapy where you shock the base of the penis. I personally don't do this. There is some science behind it that might improve blood flow into the penis. I think it's less effective for people who have this venous leak syndrome than for people who have mild arterial disease. It is expensive. It's not covered by insurance. It's a series of focused shockwave treatment sessions with someone who has the equipment. And as I said, there are some clinical studies that show benefit, but don't be surprised if you don't see a great response. Some would argue that it may help in conjunction with Viagra or Cialis or the generic equivalents of it. Two newer things that have been talked about is injecting PRP, platelet-enriched plasma, into the penis. Unfortunately, there was a recent study that showed it was no better than placebo, but something that may be a little bit more exciting just recently is actually injecting Botox into the penis. The idea being that it relaxes the smooth muscles in there. And for men who have this venous leak, there was a study from Brazil recently that showed that it did have benefit in improving the ability to sustain an erection. I personally don't have experience with either PRP or Botox, but I'm thinking that it might be worth considering, especially in a research trial, to at least show validity of the product. But again, these are all off-label, not covered by insurance, can be expensive depending on who you see and what their charge structure is like. Finally, we do have implants. It always sounds terrible, but in fact, many men are very happy with implants. You can have a malleable, which is a very simple, putting two rods into the penis itself, and you can bend it down and bend it up. I will say the vast majority of men who have implants, we have what we call the inflatable three-piece prosthesis, which involves having a pump mechanism in the scrotum, a reservoir that has the fluid in it that's put behind the wall of the abdomen, and then these cylinders that go in the penis. So that when you use the pump device in the scrotum, the penis extends and gets rigid, lengthens, and the circumference increases. And it's a pretty nice erection. The beauty is you can use it as often as you want. You will get a good result. Typically, once it's put in, you will leave it decompressed. You don't have it inflated for a period of time just to let all the incisions heal. Then you cycle the device to get the penis to expand. Again, many guys have not had good erections for a while, so it can require a little bit of time to get the full benefit in terms of length and girth expansion. But again, I have many men who we put these implants into and are thrilled with the results. The risk is infection, bleeding, something called erosion, where the cylinders break through the corpora or the cylinders that the body has, and then they have to be removed. But again, in good hands, the risk of any of these complications are very, very low. We use antibiotics before and afterwards. There are ways to medicate for the comfort of the individual. And it's oftentimes can be an outpatient, in fact, most of the time, an outpatient procedure. So in summary, there are many areas of men's sexual health that we as urologists deal with, and we have many experts within Mid-Atlantic Urology who focus on these areas. So with that in mind, please make an appointment, speak to your urologist. We do feel that we are the best people, the best specialists to be able to manage these problems. I do have a few questions that have come up, so let me take a look at them and see if I can be helpful in answering some of these. So one person asked the question about medications that we use to treat prostate cancer. When you have certain types of prostate cancer, sometimes because of advanced disease or because of getting radiation, we also put you on a hormone therapy. The hormone specifically suppresses testosterone. That's the goal of the treatment. And so, yes, you will have low T and all the side effects of low T when you're on the hormone therapy. When you stop the hormone therapy, your own testosterone levels should be restored. Although depending on which hormone you're on to suppress testosterone, sometimes the hormone bounces back very quickly within weeks, but sometimes it can bounce back within months. But again, that's something that you can deal with. Also, I believe that men who had been treated for prostate cancer and there's no evidence of disease, if they have low testosterone, it is safe to treat them. There are many studies out there that showing you that although there's always been debate about testosterone and prostate cancer, that an effective treatment for prostate cancer and a cure, it is safe to go ahead and give testosterone therapy. Question was asked that if you are effective in managing either high blood pressure, high cholesterol, or diabetes, does this reduce or eliminate the low testosterone? The answer is yes and no. Obviously, it can help with testosterone, but sometimes some of the impacts are irreversible. I should mention also that we see a lot of guys who've taken anabolic steroids when they were in their 20s or 30s, and they basically have destroyed the ability of testosterone production naturally. So if they have to stop it for various reasons, now we need to replace their testosterone because, again, they've basically permanently damaged their testes. So the question was asked, is replacement testosterone synthetic or is it natural? Now, let me explain that many people talk about bioidentical hormones. There's really no such thing. As I mentioned, when you're getting testosterone, you're replacing your existing testosterone. There's only one drug out there, or one way to embellish your own testosterone, is that with a product called clomiphene citrate or Clomid, which stimulates your pituitary gland to produce a hormone that then stimulates the testicle to make more testosterone. It may work depending on the cause for your low testosterone, but again, all the other treatments are replacing your existing testosterone with outside testosterone. Another question talks about being able to get an erection but unable to reach climax. This has been a big challenge for urologists and for physicians in general. We have great treatments to treat premature ejaculation. We don't have great treatments for men who have delayed ejaculation. Sometimes it can be on a neurologic basis. Sometimes it can be on a hormonal basis. Sometimes it can be caused because of a lack of sensitivity. There have been many things that we've proposed over the years. These are all off-label, but again, that's something to speak to urologists about, but there is no one treatment that's been shown to be effective in getting men to achieve climax if they're not able to on their own. Someone asked a question about vasodilating drugs. The answer is there are lots of over-the-counter, quote-unquote, vasodilators. Truthfully, the only class of drugs that has been shown are the class of drugs that include Viagra and Cialis. I talked about penile injection therapy because that's a direct way of dilating the spaces in there. I mentioned about Botox being experimental as a way of expanding the vascular spaces within the penis, but those are the vasodilating drugs that I know of that are effective and have had science behind it. In terms of how to administer Viagra Cialis, two things I should mention. Viagra should be taken on an empty stomach. Its absorption is affected by food, so you definitely want to take it an hour before, 2 hours after meal. Cialis is not affected by food, so you can take it with or without food. Ideally, you again want to take it 45 minutes to an hour before you want it to work, because then it has a chance to build up in your system and be more effective. Someone asked the question about Peyronie's disease, and is it dangerous to leave it untreated? The answer is no. Obviously, if it can impact and make it difficult to have vaginal penetration because of the curve, or may be uncomfortable for your partner. So that could be a reason to treat it, but there's nothing life-threatening about Peyronie's disease. Peyronie's disease is sometimes also associated with something called Dupuytren's contracture. Dupuytren's is where you have the same thing happening to your fingers, oftentimes the fourth finger, but it can be other fingers where you can't fully straighten it because there's a core of tissue that arises, much like the plaque in the penis, that prevents straightening of the penis. Again, for some men, that can be troubling, and because you can't fully straighten your hand, and may affect things that you wear, or what kinds of things you can do with your hands. But again, Peyronie's disease will not affect typically your voiding or ejaculation, things like that. Obviously, it does impact the erection. That's the whole idea. Those were all the questions that were submitted so far. If there are any other final questions, otherwise this was a treat to be involved with this webinar. Hopefully I at least started the thought process on many of these conditions. And again, feel free to reach out to me. I have offices in Bryn Mawr and Penile, or any of the other urologists within Mid-Atlantic Urology. We're a large group with offices surrounding the Philadelphia area. Thank you very much, and have a good evening.